the ISCCM I'd like to thank ISCCM for giving me this opportunity to talk to my colleague nurses who are the backbone of our system. So we'll go to the topic, the approach to a hypoxic patient in ER and ICU. So the outline of my talk would be in lines of what is hypoxia, that is the definition of hypoxia. Hypoxia and hypoxemia, though we use it interchangeably often, but there is a difference in both of them. So classification of severity of hypoxemia, identification of hypoxemia, types of hypoxia, and a bit of oxygen physiology and transport, which is essential for us to understand the mechanism of hypoxia better, management, and a couple of case-based scenarios to know the approach better, and a few MCQs before the conclusion. Coming to the definition of hypoxia. So hypoxia is a state of non-availability of adequate oxygen at the tissues to maintain the homeostasis. Coming to the difference between hypoxia versus hypoxemia. Hypoxia is the term used to label the inadequacy of oxygen at the level of the tissues, be it the peripheral tissue or at the organ level, whereas hypoxemia is at inadequacy of the oxygen at the level of the blood, which we often measure using blood gas and monitoring the partial pressure of arterial oxygen. Coming to classification of severity of hypoxemia, which is done on the basis of the partial pressure of arterial oxygen values in an ABG. So the normal partial pressure of arterial oxygen is about 80 to 100 millimeters of mercury. And as we see from left to right, there is change in the color, as you notice, from the bright red to the dark red color. And as the triangle indicates that there is falling partial pressure of arterial oxygen from the left to right, based on which it is classified into mild, moderate, and severe hypoxemia. So coming to mild hypoxemia, the patient will have a PaO2 of 60 to 80 millimeters of mercury in his ABG, a moderate 40 to 60 millimeters of mercury, and it is labeled as severe hypoxemia if partial pressure of arterial oxygen is less than 40 millimeters of mercury in ABG. So how do we identify it? Based on history and physical examination. So any problem in a patient is approached from starting from the history, especially in the ER, starting from the history that the patient gives to us, along with the clinical examination of the symptoms and the signs elicited. So regarding hypoxia, the patient can have history of cold, cough, shortness of breath, maybe history of travel where he could have contracted some kind of bug which he can develop community-acquired pneumonia, or maybe a background cardiac disease or respiratory disease which might have precipitated this acute episode. So the objective evidence of presence of hypoxia could be either a decrease in the SpO2 level in the pulse oximetry. Probably with the advent of COVID, we have pulse oximetry in each and every home. So everybody knows that the fall in SpO2 is a significant event which brings them to the hospital most of the times. And we could even do a blood gas and see the partial pressure of arterial oxygen and also the difference of alveolar to arterial oxygen content or the gradient. So here the capital A indicates that it is alveolar oxygen and A is the arterial oxygen, which we see in the blood gas. So the partial pressure of alveolar oxygen can be obtained by using a formula called as alveolar gas equation. So this alveolar gas equation here, PaO2, that is alveolar oxygen, is equal to FiO2, that is fraction of inspired oxygen, which is 0.21 at room air. Whereas if we are administering some oxygen from the extraneous source, that is our oxygen source, we should add up the extra oxygen percentage you're providing to the FiO2 value, multiplied by atmospheric pressure minus the water vapor pressure. Water vapor pressure is usually 47 millimeters of mercury at body temperature, that is 37 degrees, and the water vapor pressure we measure here is at the level of the alveolus, minus PaCO2, the value which we that is the arterial partial pressure of carbon dioxide, which we get from the ABG, divided by the respiratory quotient, which is usually 0.8. So by applying the alveolar gas equation, we derive a value called partial pressure of alveolar oxygen, from which the partial pressure of arterial oxygen is subtracted to find out the alveolar arterial oxygen gradient. And other subjective criteria, other objective criteria could be established by using some test called a 6-minute walk test, which probably might gain very importance in the COVID era again. So we used to ask our patients to do a 6-minute walk, before which we record the baseline saturation, and the patient is connected to the pulse oximetry and does a shuttle walk for about 30 meters for 6 minutes continuously. And if there is fall in saturation of 4% during the walk, or the saturation that is recorded after the walk implies that there is a significant pathology causing hypoxemia. That could be various pathologies which we'll be seeing later on. And coming to the chronic pathologies of the lung, like chronic obstructive pulmonary disease, that is COPD, or asthma, or bronchiectasis, or restrictive, any kind of chronic lung problems, and along with obesity, obstructive sleep apnea or obesity hyperventilation syndromes, where the patients can have a hypoxia for the long time, like their saturation would be, the baseline saturation would be on the lower side. There is a role of pulmonary function test, especially if the patient is not very sick. Like if the patient is very sick coming to the ICU, then there is no role of either the 6-minute walk test or the pulmonary function test. So coming to types of hypoxia, these types are divided based upon the background pathophysiology that is resulting in the hypoxia. It could be either hypoxic hypoxia, stagnant or circulating hypoxia, anemic hypoxia, and histotoxic hypoxia. We'll see these in detail. So coming to the oxygen physiology per se, the first thing we have to discuss is the transport of oxygen. So oxygen is basically transported in two forms: either the bound form, which is bound to the hemoglobin that carries oxygen from the lungs to the tissues, and then the dissolved form, that is dissolved in the plasma as well as RBC. So this is the diagram here. It is called as oxygen cascade, which is also known as Nernst cascade, named after the physiologist who has designed it. So this cascade, if you see from if you follow the arrow and see from top to bottom, so this is a partial pressure of oxygen on the y-axis, and it keeps on falling down when we move from atmosphere, that is at the level of the most left point, that is the atmospheric partial pressure of oxygen is 159, which drops down slowly to the level of about 99 by the time it reaches the systemic circulation. Because of the various events, like at the level of alveoli, as I said, there is water vapor which dilutes the oxygen and brings down the partial pressure of oxygen from 159 to 149. And from there, because of the dilution of the carbon dioxide that is present in the alveolus, the oxygen concentration falls down to 109. And because of the diffusion gradient across the membrane, the normal diffusion defect, it will drop down further to 104. And because of the venous admixture, that is some amount of the venous blood from the bronchial and the cardiac vessels open into the oxygenated side of the heart, so because of which the partial pressure of oxygen would fall further down to 99. Though we inspire a partial pressure of oxygen at 159, the partial pressure which reaches systemic circulation is usually 99. And once it reaches the tissues, it will drop down further, and uptake and utilization downstairs still further. And one more important topic that we must discuss when we are talking about oxygen transport is oxygen hemoglobin dissociation curve, which is a curve that is drawn with partial pressure of oxygen on the x-axis and hemoglobin saturation of oxygen saturation of hemoglobin on that is a percent saturation on the y-axis. So their central red line is the normal oxygen hemoglobin dissociation curve, which implies that as the partial pressure of oxygen increases, that is, as we move from left to right, the oxygen saturation, the hemoglobin that is saturated with the oxygen also increases until certain point where the curve takes a plateau, that is probably at around 97% of the saturation. The curve takes a plateau beyond which there is, even if you increase the partial pressure of oxygen, there is no increase in the percentage saturation of hemoglobin. And the other arrows, the other curves like the blue one and the green one indicates the abnormal shifting of the oxygen hemoglobin dissociation curve either to the right or to the left. So when we see the factors that affect the shifting of oxygen hemoglobin dissociation curve, the one is temperature, temperature, 2,3 DPG, that is 2,3 diphosphoglycerate, increase in H+ ion concentration. These are the factors. If when they are increased, the curve is shifted to the right, and when they are decreased and the vice versa, the curve is shifted to the left. What does this shift exactly mean? So if the curve is shifted to the right, it indicates that the affinity between hemoglobin and oxygen is decreased when compared to the normal. So there will be increased release of oxygen from the hemoglobin, and the vice versa happens when the curve is shifted to the left. That is, the affinity of the oxygen and hemoglobin is increased, so the oxygen delivery would be decreased, and which we see in the carbon monoxide poisoning as well. That is, the CO here indicates carbon monoxide. Coming to the mechanisms of hypoxia. So if you see the figure here, you could it will start from the inspired air from the atmosphere, and the green tumbler here, kind of pot, is the replicating the alveolus of our lung. From then the alveolar and capillary interface where the gas exchange takes place, and then the purple color is the arterial side of the circulation or the left side of the heart, where usually the oxygenated blood is carried from the level of heart or the pulmonary vein, to be precise, to the peripheral tissues. And then once the oxygen is taken up by the tissues and CO2 is liberated, then again it is brought back to the heart, that is the right side of the heart, from there to the pulmonary artery and to the lungs, where again there is an exchange of the gases. So this is the pathway where the oxygen travels and comes back in the form of CO2. So whenever we see a problem at the level of either the air we inspire, that is the oxygen, if the oxygen content of the air is less, or if there is a problem at the level of alveolar capillary interface, then obviously the partial pressure of oxygen that is carried by the pulmonary vein would be decreased. So this kind of hypoxia is called as hypoxic hypoxia. So whenever there is a decrease in the content of the inspired air, which usually happens at high altitudes where the oxygen is less in the atmospheric air itself, or the problem with the alveolar and capillary interface, which usually happens when the alveoli gets flooded with the fluid, like in pulmonary edema or in a stage of ARDS where there could be proteinaceous fluid filling up the alveolus, or any diffuse alveolar hemorrhage wherein the blood fills up the alveoli and interferes with the gas exchange process. Coming to the second type of hypoxia, that is circulatory or stagnant hypoxia. If you see, the left side of the heart is actually responsible for sending in the oxygenated blood to the peripheries through the systemic arteries. So whenever there is problem with the pump, that is the heart, it could not send blood to the peripheries, or whenever there is systemic vascular resistance is decreased significantly, wherein there is stasis of the blood and it could not carry the oxygenated blood further, it is called circulatory hypoxia or stagnant hypoxia. Excuse me. Then the presence of low hemoglobin in the blood, which cannot carry the oxygen that is transposed across the alveolar and capillary membrane and comes into the systemic circulation, but there is no adequate hemoglobin that actually has to carry the oxygen from the level of lung to the tissues. So it causes a hypoxia known as anemic hypoxia. And the final one is the effects that contribute the inability of oxygen to be transferred to the tissues from the peripheral circulation or the peripheral capillaries, either because of the increase in the distance because of the peripheral edema, or because of the decreased uptake by the tissues itself. So all these causes together cause the different types of hypoxia which we have enumerated. So coming to the management. So do you think that administering of oxygen will help all the patients with different types of hypoxia or different etiologies that are carrying hypoxia? So as we go further, so whenever we find a patient with hypoxemia or hypoxia, the next step we do is, as we have discussed previously, we'll do a blood gas and measure the arterial oxygen partial pressure, which we derive the value, and measure the alveolar oxygen content using alveolar gas equation. So then we will know the alveolar arterial oxygen gradient, which normally is 10 to 20 millimeters of mercury. That is, if the alveolar arterial oxygen gradient is 10 to 20 millimeters of mercury, we say that the patient is having a normal gradient. And if it is increased further, then we label it as widened gradient. So based upon the alveolar arterial oxygen gradient, as I said earlier, it helps us in delineating different pathologies that causes hypoxemia, and also helps in planning the management strategies accordingly. So if the alveolar arterial oxygen gradient is normal despite hypoxemia, we classify the patient is probably having hypoventilation. And if the gradient is widened, then again we have to see other causes like ventilation perfusion mismatch, or either a diffusion limitation or presence of a shunt. The reason behind we classifying hypoxemia into all these different categories are, not every hypoxemia responds to oxygen therapy. So in case of hypoventilation or a problem with the ventilation perfusion mismatch or diffusion limitation, we could correct the saturation of the patient by giving oxygen. And usually the response from the patient towards oxygen supplementation is also good in these three pathologies. Whereas if there is a presence of shunt, the response to oxygen is poor, which means that if the patient is having a hypoxemia because of a shunt, even if you provide 100% oxygen by putting the patient on invasive ventilator, does not serve the purpose unless we try to correct the background pathology that is causing the shunt. Coming to the treatment aspects, so as I said, we'll classify the patients and then decide on oxygen supplementation accordingly, and the need of certain drugs like antibiotics if the patient is found to have a community acquired pneumonia or any other cause of pneumonia, and if the patient has any problem with the airways, the need for bronchodilators, and if the patient has a pulmonary edema, there's a role of diuretics and steroids in the long-term diseases, especially in asthma, COPD, or interstitial lung disease. Coming to a short note on oxygen delivery devices, which again is very important, because everybody, especially the nursing staff, has to understand the limitations with each of the device we use. So I think everybody is well versed with all the devices that we use in supplementation of oxygen to the patients, either in the ER or IPD or in the ICU. So our oxygen supplementation starts with nasal prongs, wherein we can give oxygen anywhere between 1 to 6 liters per minute, and the maximum FiO2 of 0.4, and a simple face mask or Hudson mask, where we have to the maximum flow is again 10 liters per minute. And remember that whenever we put a patient on a Hudson mask, the minimum flow that should be started is 4 to 5 liters, without which the dead space of the mask will cause hypercarbia. That is, his carbon dioxide content will again increase, partial pressure of CO2 will be increased, and the maximum FiO2 that could be provided is 0.5. So there is again another mask called Venturi mask, with which we get color-coded Venturis, where we can give up to 15 liters and FiO2 anywhere between 0.28 to 0.6. Coming to non-rebreathers mask, that is, we have a high concentration face mask with a bag which acts as a reservoir. The minimum concentration that should be given is at 10 liters per minute, because we should make sure that the bag is full, and also it moves in with the patient's breathing pattern, that the bag collapses a bit with the inspiration and again expands back by filling the reservoir. And the maximum FiO2 that could be delivered with NRBM is 0.8. So I think most of the nurses, especially in the ICU, should be well versed with the HFNC, that is high flow nasal cannula, with which we can deliver up to 60 liters of minute, and with added advantages of heated air and also the humidified air. And the maximum FiO2 we could deliver is here is actually varied based upon the patient to patient. Like if the patient is having an open mouth or more opening the mouth, then maybe the maximum FiO2 that is delivered might change. But usually the patient stays with a closed mouth. The maximum FiO2 that is set in the literature is about 0.9. And when we could not provide adequate oxygen to improve the saturation with all these strategies, then we need to resort to the ventilator, either through a non-invasive interface or invasive ventilation, wherein we could deliver up to FiO2 of 1. And I think these things should be kept in mind whenever we start on any oxygen therapy device, like the minimal oxygen that has to be given and the maximum oxygen that could be given with the interface. If the patient is requiring more oxygen than that is specified for that particular device, then we need to step up to the next device. Like for example, if you put a patient on nasal prongs and the patient is not getting better even with 4 to 6 liters of oxygen, then we have to change the interface rather than putting 10 liters on the nasal prongs. This should be kept in mind. So we'll see a couple of cases to know the approach towards the hypoxemic patient. So here comes a patient, a 40-year-old gentleman with no known comorbidity, presents to ER with history of fever and cough for 2 days, shortness of breath for 1 day, which has actually progressed from grade 2 to grade 4. Coming to the vitals of the patient, his blood pressure recording is over 100 over 60 millimeters of mercury, heart rate of 120 per minute, and SpO2 is 87% on room air, respiratory rate of 32 per minute, and he is febrile at the time of evaluation in ER with a temperature of 102 degrees Fahrenheit. So when we come to the approach of this case, the abnormalities that you could make out clearly are, apart from the history, like patient is having a fever, cough, and shortness of breath, which probably points towards some lung pathology. If you see other vitals, the heart rate is 120 per minute, respiratory rate is 32 per minute, with saturation of 87% on room air. So whenever we see a patient of this kind, that is patient is having hypoxia with a saturation of 87, with tachycardia, that is heart rate of 120 per minute, and tachypnea, that is respiratory rate of 32 per minute. So we approach this patient by recording the history and clinical examination, symptoms that the patient tells and the signs we elicit, like tachypnea, tachycardia. So as we know that the patient is hypoxemic, we start with oxygen and then draw in some labs like arterial blood gas, with which our thought process should begin. So as I said earlier, once we get an ABG, then we draw some values from the ABG, that is the partial pressure of arterial oxygen, then partial pressure of carbon dioxide in the artery. Along with that, we do put a Albert gas equation and find out the A gradient of the oxygen, based on which we will divide the patient into either having hypoventilation or VQ mismatch or having a shunt, and then based on that we'll proceed further. Coming to case 2. So this is a 35-year-old female on invasive ventilation, day 3 for severe ARDS, was maintaining saturation of 94%, more than 94% for the last 48 hours, develops hypoxemia with ongoing monitor and ventilator alarms. And the monitor alarm reads as low SpO2 alarm. Coming to ventilator alarms, can anybody guess what could be the ventilator alarm? So coming to the approach, so I would take this opportunity to again reiterate 100 times that you should never silent the alarm without noticing what actually the alarm is and what you have to do to address it. I do accept that there will be certain false alarms because either of the patient pathology itself or because of the machinery problem, but never silent an alarm without noticing it properly. So as I said, the monitor is alarming SpO2 low, and the possible ventilator alarms would be, number 1 is high peak airway pressure alarm, that is because of the presence of either secretions or any kinks in the tube or block in the tube because of the secretions, or patient breathing against a ventilator, that is having asynchrony, or patient biting the tube causing the block of the tube, or there could be a tube disconnection. And whenever there is a disconnection alarm, we should see from end-to-end approach, that is you start looking from the patient end to the machine end, or the vice versa, from the machine end to the patient end. This would actually give us the proper place where it could disconnect. It does not mean that always the tubing should disconnect either from the ET tube or from the ventilator end. There could be loss of connectors in between, which can even cause the tube disconnection alarm. And the thought process that should begin here is, as I said, it depends upon the alarms we find out, and there is no alarm at all, but only monitor alarm that is telling us that the saturation is low. It could be because of the worsening pathology of the patient. It can be either hospital-acquired pneumonia or ventilator-associated pneumonia, or there could be worsening in the disease process of ARDS as well, with which the ventilator requirement increase either in the form of PEEP or proning or going to the final step of VV ECMO. So we'll solve 4 to 5 MCQs before concluding it. So the first MCQ is, I have put up the MCQs as a case scenarios with which you have to identify which type of hypoxia is this on the case.
I think we can unmute the participant if they can answer or put their answer in the chat box. That will be good for the discussion part.
Yes, sir. Mr. Dhawan, are you available?
Others will let them answer in the chat box, or they have any questions or queries in the presentation. As of now, they can ask the questions in the chat box or on the Facebook live page, which will be copied over here, so that we can see. And for every MCQ, I mean, they can put their answers in the chat box. If there's any query in the answer, then we can always go ahead and address it.
Perfect. So I'll read out the first MCQ. There is a 65-year-old male, known case of coronary artery disease, COPD, presented to ER with history of cough with expectoration for 4 days, fever for 2 days, shortness of breath from today morning. And the vitals were blood pressure of 120/70 millimeters of mercury, heart rate of 110 per minute, saturation of 78% on room air with a respiratory rate of 34. And ABG is pH of 7.35 with PO2 of 55 and PCO2 of 48. So from the case history and the background given, the patient definitely has hypoxia. So which type of hypoxia could be attributed for this patient? A is hypoxic hypoxia, B anemic hypoxia, C stagnant or circulatory hypoxia, D histotoxic hypoxia. You can put in answers in the chat box. I can see one C. Any other answers? Okay, so one more A. Any other answers? Okay, so we would see what it is. So as I said that in the mechanism of hypoxia, when we are discussing about mechanism of hypoxia, any abnormality at the level of alveolus, either because of the decreased partial pressure of oxygen in the atmosphere or any abnormality at the level of alveolar capillary interface, causing decrease in the oxygen concentration in the pulmonary vein that carries blood to the left side of the heart, this is called hypoxic hypoxia. So if you go to our question now, the patient is having hypoxia, that is for sure, either from SpO2 or from PO2 level in the ABG. When you see the history, there is history of cough with expectoration for 4 days with fever, shortness of breath. So we think in the lines of probable community acquired pneumonia, which means that there is problem probably at the level of alveolus being flooded with the material in the pneumonia that is causing hindrance in the gas exchange, which is because of hypoxic hypoxia. So the answer for the first question is hypoxic hypoxia, option A. So we'll move forward. Second question, I'll read it for this. 77-year-old gentleman, known case of coronary artery disease post PTCA with history of recurrent heart failures. Presented to ER with history of swelling of the feet for 4 days, breathlessness with wet cough for 2 days, decrease in the urine output from morning. And his vitals were blood pressure of 80/40 millimeters of mercury, heart rate of 130 per minute, saturation of 75% on room air, and respiratory rate of 38 per minute. And his ABG shows pH of 7.35, PO2 of 50, PCO2 of 25, bicarbonate of 18, and lactate of 8. So again, you have to pick up which type of hypoxia it is: hypoxic, anemic, stagnant, or circulatory histotoxic hypoxia. So any answers? I can see one C. Any more answers? So from the history and the labs, in labs we could clearly make out that the patient is having hypoxia, that is at SpO2 of 75% with PO2 of 50, which clearly tells that the patient is hypoxia. So when we see the background pathology, the patient is having history of coronary artery disease with recurrent heart failures, now presenting with swelling of feet, breathlessness with wet cough for 2 days, decreased urine output, which indicate that there is problem with the pump, that is the heart causing recurrent heart failures. So when we go back to the pathology, that is the mechanism slide, as I said, whenever there is problem with the heart, it is not able to carry the oxygenated blood from the heart to the peripheries, which means that the hypoxia is circulatory hypoxia or stagnant hypoxia. That is, answer is C. So coming to the third MCQ, here comes a 27-year-old female homemaker with history of polymenorrhea and menorrhagia, that is frequent menstrual cycles and increased flows whenever she gets a cycle for last 1 year, for which she did not seek any medical attention. And now she presents to ER with complaints of shortness of breath on exertion, which initially was on moderate to severe exertion, now progressed even with minimal exertion. Coming to the vitals, the BP is 110/60 millimeters of mercury with heart rate of 100 per minute, SpO2 of 85% on room air, respiratory rate of 32 per minute. When we investigated, her HB turned out to be 5 grams with TLC of 13,000 and platelets of 1.5 lakhs. So now again, you have to pick up what is the cause of hypoxia. Yeah, I can see 1B. Any other answers? So it is very evident from the background history that she being reproductive age group woman with having a polymenorrhea and menorrhagia and HB of 5. So it is anemic hypoxia. So when we go back to the mechanism slide once again, as I said, when there is no adequate hemoglobin to carry the oxygen from the arteries, that is the pulmonary vein, to the periphery, then this is called anemic hypoxia. And in our case, it is evident the patient is having HB of only 5. So this B is correct. Coming to question number 4, here comes a 22-year-old female working in jewelry industry where gold plating of the ornaments is done. She was brought to ER with sudden onset of headache, dizziness at work. On arrival, she was drowsy with saturation of 75% on room air and blood pressure of 60/40. Her ABG was showing high iron gap metabolic acidosis with lactates of 14. So any answers? A female working in gold plating industry presents with sudden onset headache, dizziness at work. She was drowsy with saturation 75 with high iron gap acidosis and shock. I can see 1D. Yeah, 2 Ds. Any other answers? Yes, the answer is histotoxic hypoxia. The clue here is the female working in gold plating industry. Like in gold plating, they usually use substances like cyanide as a solution to apply this gold plating to the ornaments. So there is high chance of them having cyanide toxicity if they are not using personal protective equipment. So whenever there is increased level of cyanide in our circulation, or if they inhale the cyanide, what happens is at the level of tissues, it does not allow the oxygen to be taken up by the tissues, causing histotoxic hypoxia. Okay, so the answer D is correct. So coming to the last MCQ. So from the classification of severity of hypoxemia from PaO2, what is severe hypoxemia here? Hypoxia with PaO2 of less than 70, less than 60, less than 50, less than 40. What is severe hypoxemia? Any answers? Any answers? What is severe hypoxemia? B. I can see 1B. Any other answers? So when we go back to the classification of hypoxemia from the PaO2 values, you can see that mild is 60 to 80, moderate is 40 to 60, and severe is less than 40. So the answer is D. Okay, so here ends the MCQ session, and the take-home points from my lecture would be always check the pulse oximeter probe and the pulse oximeter waveform, that is plethysmograph, in the monitor. The saturation, that is SpO2 reading that is in the monitor, is taken as valid only if the waveform is regular. So this waveform should be regular. Whenever there is extraneous disturbances, like either coming from the light source, or the patient is having nail polish, or the patient is moving his or her finger when the pulse oximeter recording is going on, causing any distortion in the waveform, then this figure will not be taken as correct. So whenever the waveform is regular, then only we take this figure as correct. So the patient is having saturation, that is less saturation, even if the waveform is regular, then only it is called as hypoxemia or hypoxia. And we have to establish hypoxemia by either checking the pulse oximeter waveform or by performing a blood gas and looking at the PaO2 of the patient. And whenever any alarm comes, especially on the patient on a ventilator, we have to run checks from one end to other, that is either from the patient to the machine or from the machine to the patient. And you should know your oxygen delivery devices and the limitations. The limitations in the sense the maximum oxygen that could be delivered for the particular device and the minimum oxygen that should be kept, that is especially in case of Hudson's mark, where the dead space has to overcome by putting at least 4 to 5 liters of oxygen. And specific management strategies based upon how we classify the patient from the PaO2 and P-alveolar O2. Thank you. Any questions? You can post your questions in the chat box, or you can unmute yourself and ask questions.
Yeah, Dr. Bharath, can you just please slightly educate us slightly more on the alveolar gas equation? I mean, yeah, you find, I mean, on the last 4 questions, you find that they are hypoxemic. How do you use alveolar gas equation in that scenarios?
Yes,
do you do it regularly, or only when you think that you are not able to get back into the scenarios?
No. Ideally, while we are reading out any EPG or we are evaluating any APG, so arterial blood gas itself will have 2 components. One is evaluation of the oxygenation status, one through straight away PO2, And along with that, we have to do a alveolar to arterial oxygen gradient, with which we could actually classify the patient into the which group the patient falls, based on which we'll understand whether the patient might respond to oxygen or might not. So I would like to repeat this algorithm once. So whenever we, for example, I've done a ABG on a patient who looks hypoxemic to me from the monitor reading of SpO2, that is probably saturating at about 80 or 85. Then I would do an ABG to see the PO2 level. And also along with the PO2, I must measure alveolar arterial oxygen gradient every time, because it actually classifies the patient into the different etiologies, and also lets me know whether the patient responds to oxygen or patient might not respond, and I should look for some other etiology, some other background to correct the pathology, like especially in the case of shunt. So in case of in case of hypoxemia, if I go ahead and do the alveolar arterial oxygen gradient from the alveolar gas equation, and if I see that the patient is having a normal gradient, that is gradient of about 10 to 20 millimeters of mercury, so the pathology could be because of the hypoventilation, that is patient is not breathing properly, or the mixture of air that he is breathing has less oxygen. So then the response to oxygen for this group of patient would be good. And if there is widened gradient, that is widened alveolar arterial gradient, that is if the A gradient is more than 20, more than 30, more than 100, then they might come into other three categories, that is the V/Q mismatch, the diffusion limitation, and shunt. Here the history and clinical examination helps us in identifying. For example, if we go for the diffusion limitation group, there could be a pulmonary edema with, then on your examination you can find out crepitations, or the disease like patient could have a severe ARDS. By looking at the X-ray, you can see the infiltrates and all having diffuse infiltrates spread all over the lung on both sides. Then you could understand the diffusion limitation. And V/Q mismatch and shunt, you would identify based upon the background pathologies. So the response to the oxygen is, again, as I said, is poor in case of shunt. We need to correct the cause of the shunt, then only the patient's hypoxemia will improve. Just by supplementing oxygen is of no use in a case of hypoxemia, which is actually because of the shunt. Here the shunt means that the deoxygenated blood is going back into the systemic circulation without getting oxygenated. So you have to treat the underlying pathophysiology rather than simply providing oxygen, because simply increasing the FiO2 or concentration of oxygen that we are providing from the outside does not solve the problem here. Any other questions?
I think I'm not seeing any questions being posted over here. And Dhaval, did you find any questions in Facebook Live? I think we got about 10 attendees. Any questions from the attendees? Identification slide. I think you got a question, Bharath. Can you elaborate on the identification slide?
Yes, I'll go back. So how do we identify that the patient has hypoxemia? So any identification will start with history. So presenting symptoms and signs that the patient is having cough, cold, shortness of breath, or the patient is having any long-term disease like COPD, asthma, or any restrictive lung disease, or presence of history of travel after which the patient developed all the symptoms. These could point us towards any specific pathology. And other objective identifications would be from the pulse oximetry, where the saturation would be less, or from the blood gas value of decreased PaO2 or AA gradient, that is alveolar to arterial oxygen gradient. The alveolar gradient, we obtain alveolar gradient by using a formula called as alveolar gas equation. That is PaO2, that is capital A is alveolar oxygen, is equal to FiO2, that is fraction of inspired oxygen, which is usually 0.21 in room air, that is 21% on room air. We take it as fraction, that is divided by 100, so which is 0.21 into P atmos, again is the atmospheric pressure, which is usually 760 millimeters of mercury at sea level, and then pH2O is the water vapor pressure at the level of alveolus, which usually is 47 millimeters of mercury at a normal body temperature, that is 37 degrees centigrade, minus PaCO2 by R, or respiratory quotient. PaCO2 is the partial pressure of carbon dioxide in the artery. We derive it from the ABG sample, and RQ is the respiratory quotient, which is usually 0.8. So by using this formula, so we need an ABG from which we have to take the PaCO2 and FiO2, that is if the patient is at room air, we take it as 0.21, or if we are giving oxygen from outside, then we need to add up to the FiO2. And atmospheric pressure and water pressure, these are standard, 760 millimeters of mercury and 47. And PaCO2 we derive from the ABG, and this gives PaO2, that is alveolar oxygen partial pressure. When we subtract this from PaO2, that is arterial partial pressure of oxygen, then we get the AA gradient. The normal AA gradient is 10 to 20 millimeters of mercury. If the alveolar arterial gradient is more, that is if it's more than 20, more than 50, or more than 100, it could be even more than 200. So whenever there is an increased gradient, it means that the cause of hypoxia will fit into that is this increased alveolar artery gradient will help us in localizing the pathologies. And other tests which we can do on the bedside in evaluating hypoxemia, these tests are usually in not very sick patients. We have done it in COVID, either at the patients when they are in home isolation or in wards usually, where we ask the patient to do a shuttle walk, that is forward and backward walk for about 6 minutes with monitoring. That is, we take a pulse oximetry reading at rest before starting of walk, and again the patient continues to be monitored with the pulse oximeter during the walk and after the walk. So if there is fall in oxygen saturation from the baseline, that is before starting of the walk, of more than 4%, that is the patient is having a saturation of 98% at rest before starting of his walk, then we ask the patient to walk for 6 minutes, and if the saturation falls to 94 or less than 94%, either during the walk, even before the patient could complete 6 minutes, or after the walk, is a significant value. That is, the difference of more than 4% is significant. And in case of long-term diseases like asthma, COPD, any restrictive lung disease because of the kyphosis of the spine, we can do a pulmonary function test to check for interval worsening. That is, the patient has obstructive lung disease, that is asthma or COPD, from probably from good amount of time. So we do have a baseline pulmonary function test before the patient comes with this particular new episode. So when we perform pulmonary function test, we compare it with the past test and see if there is interval worsening. So this is how we identify the presence of hypoxemia. Any other questions? Mr. Dhaval, are there any questions on the Facebook Live?
Can we conclude? Dhaval? Anyone from the IS system team?
Mr. Dhaval, are there any questions on the Facebook Live?
Steps are
Can you please share them here so that I can answer them?
विचारते तिला सांग घरी जा. ना मैडम 10 मिनट दो खाली, मेरा तो 4 बजे स्टेप सेशन खत्म हो जाएगा ना, फिर जो बोलोगे वो. चलो.
It is an excellent elaborative presentation by Dr. Bharath. I mean, we always need to know how we need to approach it. So we always need to know what are the various measures or approaches that we need to take. All a hypoxia, as he clearly elucidated, doesn't respond in the similar manner. You always need to go stepwise, a practical approach, okay, or a stepwise approach, and it is basic butter of our day-to-day practice. So we all should be systematic and very skeptical about each and every hypoxic patient. You may have a combination of these things sometimes. Okay, so whenever you are having a problem of hypoxia not resolving to whatever measures you're doing, again go back to the basics, start from point A and go by the approach how Dr. Bharath has clearly explained in the last 1 hour. So probably that will help us in giving a better care for all your hypoxic patients. Thank you, Dr. Bharath.
Thank you, sir. I would like to thank ISCCM and also Mr. Dhaval for coordinating an organization. Thank you. Thank you, Balasa, for your time.